Thank you, Ms. Pittman. Thank you to all of our panelists for your presentations. Members, any questions or comments? Mr. Levine.
Yeah, thank you for those great presentations. I introduced an MCO tax proposal during an extraordinary session because I feel the urgency to provide the care that your members are trying to provide for people. And I know that we've had a huge challenge on the reimbursement rates, trying to get the level of funding that we need. But what really frightens me is having to cut over $1 billion of funding and the services that represents, which we will have to do if we don't resolve this now. When you're thinking about what those cuts look like, what are you seeing? What would that mean in reduced services? Where would you anticipate those cuts to come from? I know you're not the administration, but where would your fears be as to where would they go, and how would that affect those lives?
I'll start first. The way the hospital rates are structured and looking at the number of beneficiaries in the MediCAL program and the services they rely on, OB services are extremely important for this population, and they're already pretty scarce. When you look up in Northern California, and when you look between Redding and the Oregon border, I think there's one OB provider. I would hate to see that hospital stop providing OB services because they couldn't attract providers to provide those services. I don't know what those women would do. Of greater concern, though, I already raised the really big concern that we've been seeing over 1 million new MediCAL visits in the last year. If we cut $1 billion more out of MediCAL rates, especially to the physician providers, I'm probably going to see 2 million more MediCAL patients coming in hospital emergency rooms. And it's going to cost the state more because it's more money to reimburse a hospital for an emergency room visit than a primary care physician for getting that care in the right place. So a big concern is the hospital emergency room and what that will do to exacerbate overcrowding that exists today.
I would assume that the progress we made regarding the MediCAL cuts that we've made in the last couple of budgets, I would assume that would get wiped away as a first step, which would probably, hurt the MediCAL program for a long time, because I think part of the reason that doctors are not volunteering to participate is that it's the unknown of where it's going to be, and if we have to go backwards after we were finally able to reverse some of the things that happened way back in 2009 and 2010, I think it would hurt the program going forward.
I think it would just really move us backwards. Especially in DentaCal, we're primarily fee-for-service except for a few counties, Sacramento and LA. And so there's an even greater, I think, connection between rates and access there. And so if you cut the rates, you're going to see more and more providers dropping out. And I think what we've seen with our dentists is folks saying, okay, we're really glad that we got the 10% because now we can stay. And so I don't know that 10% is going to bring more providers back in, but I think we're going to be able to keep the ones that we have. And so any further cuts is really going to continue to decrease the number of providers who participate, the number of patients that they take. I think our members face a lot of the same issues that the doctors face, where you may be able to take a small handful of MediCAL, but if you continue to lose more and more money on it, you're going to be able to do less and less of that because you're subsidizing with your other patients. And we have the same issue with specialty dentists, that it's difficult for our general dentists who are taking substantial percentages of MediCAL. Maybe they work in a clinic, that's just the way their model is, that they don't have anyone to refer their patients to when they need a root canal or an extraction or other sort of more complicated dental procedures. So I think it'll just go in the opposite direction, and that kind of frightens me because we're already sort of already terrible. But that's the only way I see it going.
And the only comment I'll add, because I'm not in administration, but from a physician standpoint, I see that any time the system is burdened, everybody suffers. So it's you and your family as well as us on the panel and the people sitting behind me that will find a distinct decreased access to care when the system is overburdened, where patients are not accessing care until later in the system trickling downhill. So by the time the patients get to an obstetrician and have 16 problems to see, by the time they get to the emergency room and eat up all the services of an ER because they come in so complicated, that's physicians that are tied up with a complicated patient. They could be seeing another patient who's part of a managed care system, who's not MediCAL. So it hurts all of us when MediCAL is under-reimbursed. It hurts all of us. That's my point.
Dr. Wood.
First of all, I want to thank you, the panelists. I think I really appreciate your presentations. And having been a provider, a dental provider for almost 30 years, I get it, and a MediCAL provider for a very long time. Obviously, the cuts that happened in 2009, in my opinion, really decimated our provider system, whether it's hospitals or physicians or dentists, and it's going to take time to rebuild that. So, as we look at funding, I applaud your interest in and moving forward on a tobacco tax. I think that's important. Obviously, the MCO tax is going to be really, really critical to us. But I just want to emphasize something that you brought up, and I think it's really critical for people to understand. When you're talking about rates, we're talking about rates that to increase so that physicians and dentists and other providers don't lose as much money as they're losing now to serve the population. And that's really, really important. It's not that providers are trying to make a living out of this, because in the fee-for-service model in particular, you can't. It doesn't work that way. So it is about, we are already subsidizing care. It is about being able to subsidize care in a way that allows us to treat more patients, and not in a way that limits our ability to do that. And so I think people need to understand, when you talk about rate increases, it's just they want to make more money. No, it's really we're trying to stabilize this to treat more patients and not lose more money, and therefore burden the system anymore. And your emphasis on how this affects our care, or other people's care who are not on the MediCAL system, there, absolutely, you just hit the nail on the head. If you're going into a hospital that is already overburdened, trying to treat a population of patients that could be treated in another way, in a simpler way that is less expensive, and you need that critical care, and yet you have those basic preventive services, that access that you're losing is a critical part of this as well. So it does truly affect everybody. It is not just the MediCAL population. The more you overburden our system, the more people are affected, and it's not a positive effect, obviously. So I really thank you for your presentation and the clarity that you have brought to the message you've brought to us. Thank you.
Mr. Mace.
Is the proposed MCO tax the proper way of funding for these services? What's the proper way of funding for these services?
That's a very complicated question, because there's not just one solution, I'm sure. If the MCO tax is not renewed, then we're way back to worse than 2009 in trying to bring more providers on board and trying to stabilize this unstable system. So at least the MCO tax has to be reinstituted. But beyond that, there have to be other sources like the tobacco tax, like other things I can't even imagine, that if I was a legislator, I hope I'd have the time and resources to come up with an imaginative other thing that in addition would help to fund MediCAL services. But the MCO tax is at minimum must have. And then beyond that, there must be other things.
Anybody else want to give it a shot?
I would agree with Dr. Haskins. We're sort of here to tell you what we're seeing on the ground and what our take on the system is. And I think that there is a great fear amongst the provider communities that we're going to lose the MCO tax, and we're going to have a hole, and we're going to be going back to 2009. I think one of the things I actually forgot to mention, around forgetting the exact year, but adult dental benefits were cut several years ago, and there was just a huge crisis. All of a sudden you couldn't get any dental care at all. So if you had, you couldn't get any. And what we've seen with the reinstatement of those benefits is that folks have this huge amount of care that's just been backed up, that they've just been waiting on. And so I think we are looking at what happens if there isn't that revenue, and are not, don't look at that as something that would be positive. And so the MCO is something that we've had, and we think that there are some opportunities to look at how to restructure that to maintain those dollars, and so that we know that we need to get at least there and build on that. And there are a couple of things on the table. The tobacco tax is one, and if neither of those work out, then I think we're going to need to start looking at other types of revenue.
But just to make sure, the existing MCO tax is not the same as the proposed MCO tax. And so the question is that the proper way of funding MediCAL and DentaCal services? I mean, if you want to give it a shot again. If you
don't feel it, you have to answer that question if you don't feel it.
But
that it's in your area.
I do have something.
I have a member who wants to take a shot at it too.
Take a crack at it.
No, all I would say is I think the health plans have made a commitment. They made a commitment with the initial MCO tax, and they're interested in trying to find a solution because they're part of the system as well. And so if they can come to an agreed upon solution that then they can convince the legislature and the governor to support, obviously I think that would be that's the straightest line, I would say, as far as finding a revenue replacement for what we know is going away, because the feds have told us we can no longer use the structure that we have currently.
Let's go to Mr. Levine.
Yeah, thank you to the panel for making an attempt at answering that. So the MediCAL budget is larger than $1.1 billion. It's funded by a number of different mechanisms. What is great about the MCO tax is that it leverages federal funds. That's why the MCO tax is on the table. We want to leverage federal dollars. We don't want to leave federal dollars in Washington. We're California. We want to bring that money back from the taxes that Californians pay. And the MCO tax enables us to do that in a pretty wonderful way, to provide a great service for nearly a third of Californians who rely on MediCAL, nearly a half of California kids. And so when the federal government informed us that our MCO tax does not meet the federal guidelines, that's why the current tax needs to be repealed and replaced with one that actually does leverage federal funds so that Californians don't leave their tax dollars in Washington.
Any other comments or questions from members? Okay, with that, I'd like to thank once again the panelists for your participation. Thank you so much for your contributions to today's discussion. We'll go to our panel number 2 of the MediCAL program stakeholder perspective. Michelle Doty-Cabrera, Healthcare and Research Director, SEIU California. Linda Wynn, Legislative Advocate, Western Center on Law and Poverty. Anthony Wright, Executive Director, Health Access California. Whenever you're ready, Ms. Cabrera.
Thank you, and good afternoon, Chair and members. Michelle Cabrera with SEIU California. We are the state's largest union representing over 700,000 workers, including 150,000 private and public sector healthcare workers and an estimated 300,000 workers in home care and long-term care. Through our work in the healthcare system, throughout our work in the passage and implementation of the Affordable Care Act, and as representatives of low-wage workers, our members are deeply committed to the long-term success and sustainability of the MediCAL program. MediCAL is now more important than ever before, and we need to invest in its financial stability now. Due to how we finance our state general fund, our state budget moves in boom and bust cycles. When times are bad, as we saw in the recent recession and in the dot-com bust before it, demands on the MediCAL program and social services increase just as our general fund takes a nosedive. MediCAL, like other health and human services programs, is also dependent on general fund with no built-in protections or minimum funding guarantees. So when times are tough, we cut those programs. That's how we got the 10% fee-for-service provider cut, the elimination of adult dental benefits just mentioned, and other optional MediCAL benefits. All told, some estimates put the cumulative impact of this last recession's cuts at around $15 billion to the health and human services area of the budget. And we have yet to recover from all of those cuts. Future economic downturns will come, and with it, new challenges for the non-98 side of the budget. Last time, it was the court's mandate to fix our corrections system. Next time, it might be fires or droughts or some other crises not yet known today. SEIU knows that this downturn is inevitable, and holding on to as much funding diversity in MediCAL is crucial to our ongoing sustainability. No, we can't afford to lose over $1 billion in revenues to the program today provided by the MCO tax. However, I don't get the sense from anything we've heard from the legislature that the status quo is the benchmark or even the goal, that we're interested in plugging general fund holes. The consistent message with MediCAL has been that we need to do better. We need to do better by our beneficiaries, some of whom you'll hear from today in our public comment, and through our consumer advocates, the third of our population covered by MediCAL. And we need to do better by the providers, the doctors, the nurses, the radiologists, the dietitians, to name a few, who hold our safety net together. On the MCO tax, we would argue that come January, our time would be better spent trying to figure out how to improve access in MediCAL in the new era of managed care, rather than hearing from beneficiaries, providers, and taxpayers about how the proposed $1 billion in cuts will push them further out off the edge. We would also argue that in order to have that conversation, the state needs to set its sights on additional funding streams beyond the MCO tax to fund healthcare, IHSS, and developmental services. Additional non-general fund revenues, such as the tobacco tax and other options under consideration, can help ensure that we move from plugging holes and backfilling in MediCAL in the good years and slashing it in the bad years to actually improving and strengthening it in the long term, as that strength and sustainability is desperately needed in our safety net. The only alternative is for us to not need MediCAL as much. The statistic has been said over and over. MediCAL now covers 1 in 3 Californians. What's so remarkable about the statistic is what it says about widening income inequality in our state. And this is using the federal poverty measure, which doesn't fully capture California's cost of living. When adjusted for cost of living, we have more people living in poverty than anywhere else, and nowhere is that poverty as concentrated or severe as in our Central Valley, which consistently ranks among one of the poorest regions in the nation. Along with that poverty comes off the charts asthma, diabetes, heart disease, all of which disproportionately falls on our communities of color. If we continue along this path, we'll only increase the demand for programs like MediCAL. So as we think about how to ensure the success and stability of MediCAL, we need to make sure that the state's policies overall help lift people out of poverty through increased minimum wage and by keeping individuals on employer-sponsored coverage. Thank you for your time today and for the opportunity to speak to some of what ails our MediCAL program.
Thank you, Ms. Way.
Good afternoon, Chair, members. Linda Way with Western Center on Law and Poverty. We work closely with local legal aid programs that work directly with low-income consumers. Thank you for the opportunity to provide a consumer perspective on MediCAL access. Much of the focus on MediCAL access has been on low provider rates. While $16 a visit for reimbursement is an astoundingly low reimbursement rate, it's important to note that this rate is specific to fee-for-service MediCAL, and only a quarter of MediCAL enrollees are fee-for-service MediCAL. The vast majority of MediCAL beneficiaries, 9.7 million and increasing, are enrolled in managed care plans that are paid actuarially sound rates. Therefore, it is up to the plan to ensure that these providers are paid adequately to ensure timely access to service. Of the 3,800 MediCAL service calls that our legal aid partners have handled in 2014, nearly a third relate to access to care, specifically lack of network adequacy, delays in service, access to specific providers in service, as well as denial and reduction of services. Mirroring enrollment numbers, 3/4 of these access cases are for managed care enrollees. Specific to network adequacy, we've heard from many rural beneficiaries about the difficulty accessing specialty care. In some cases, these beneficiaries have to travel more than 4 hours one way to see a specialist, but due to lack of transportation may not be able to access this needed medical care. MediCAL beneficiaries are also asked to travel farther to see primary care providers or wait longer for appointments as their local clinics are so impacted that they cannot provide timely appointments. In addition, we've heard from patients being assigned to specialists who cannot provide surgery because they do not have operating privileges at the plan's contracted hospital. It doesn't make sense that a managed care plan would assign a beneficiary to a specialist who cannot provide needed services. In terms of access to specific providers, the auditor's report and CDA's testimony highlights the lack of access to dental care for children. Adults face a similar problem. We've also heard multiple cases of consumers being denied mental health services from health plans. The cases we hear put a real face to the MediCAL program, which relies heavily on the MCO tax. Passing an MCO tax is critical, as failing to do so will result in a $1.1 billion hole. Based on MediCAL consumer access problems, we urge the committee to focus on holding MediCAL plans accountable for access in their networks, access to specific services, including dental care and mental health services. We agree with the LAO's recommendation in March to refocus legislative oversight priorities in monitoring the MediCAL managed care system and have submitted specific comments to the department that we can share with the committee. Thank you for the opportunity to testify and happy to answer any questions at the end of the panel.